Thank you very much. Thank you very much for the kind introduction, and it's truly a pleasure to present again at Echo Rounds at St. Michael's. So the topic that I want to talk about today is often a topic that results in a lot of discussion and occasional disagreement at the heart team table. So edge-to-edge repair in end-stage heart failure. Now, if you think about this therapy, it's started off as a salvage option for patients with degenerative MR that now progressed to being a guideline-endorsed Class 1 recommended therapy for selected patients with secondary MR. And how we got here and how we applied this therapy to the sicker end of the heart failure spectrum is what I wanted to unpack with you today. This is my disclosure. So I wanted to start off with a single sentence that hangs over everything that I'm going to say over the next 45 or 50 minutes or so. Stage D heart failure, the mitral valve is rarely the disease, the ventricle is. And when we intervene on the valve, we're modulating a downstream effect or a consequence of heart failure. And this framing should inform every decision that we make about patient selection, procedural goals, what we tell the patient to expect, and how we define a successful procedure. So I want to frame the talk around three questions. Who amongst our end-stage heart failure patient is going to benefit from edge-to-edge repair, and how we do reconcile the landmark trial data? Initially, on first glance, the data may look conflicting with the co-opt in MITRA-FR, and most recently we had the Reshape HF2 trial that make things seemingly a little bit more complicated. And how do we integrate edge-to-edge repair into the advanced heart failure algorithm along with medical therapy, device therapy, and advanced therapies? And finally, what are the echocardiographic and hemodynamic red flags that would make us pause or pivot to a more of a bridge strategy rather than a definitive single intervention? So I want to start off with a case, a 58-year-old man with non-ischemic cardiomyopathy. So EF is 28%, NYHA3 symptoms despite maximally tolerated medical therapy and 2 hospitalizations in the last 9 months. Most recent echo showing severe MR, severely dilated ventricle, PA systolic pressure elevated, around moderate pulmonary hypertension, and mildly reduced RV function. This is what the MR looked like. So is this the right patient for edge-to-edge repair? And if yes, what's the goal of your disease? Is it disease modification, or is it a bridge to transplant, or is it just palliation? Now, keep that thought in mind. I'm going to come back to this case later on. The pathophysiology is worth some regrounding because it impacts the way we think about therapeutics. So secondary MR is not only a marker of ventricular dysfunction, it's actually a driver of decompensation. A dilated ventricle leads to dilated pap muscles that dilate apically and laterally, resulting in leaflet tethering and malcoaptation, resulting in MR. Atrial dilatation tends to make things even worse, and oftentimes you have atrial functional MR layered on top. The hemodynamic consequence is important. You have mitral regurgitation raising the left atrial pressure, which raises the pulmonary venous pressure. And with the low cardiac output, you have this self-perpetuating cycle where you have heart failure resulting in MR, resulting in pulmonary hypertension, resulting in RV failure, resulting in more heart failure. And this is not a benign condition. Studies for years have shown that moderate or greater functional MR in low EF doubled the mortality at 1 to 2 years, independent of LV systolic function. This is the conceptual lens that I want you to interpret what we say later today through. So this is the famous figure published in 2019 from JACC Cardiovascular Imaging, and it's based off the Gorlin principle, or the Gorlin equation. So what that says is that when you have a dilated ventricle, the number used in the example is 220, 250 mLs with an EF of 30% and a regurgitant fraction of 50%, you expect an EROA of around 0.3. So using this, you can divide the secondary MR into 2 different phenotypes. Proportionate MRs when the EROA is what you would expect given the degree of LV dilatation. So the ventricle is doing the driving and the valve is along for the ride. And when you intervene on the valve in isolation, you tend to have, the intervention tends to disappoint because you're treating the symptom and not the root cause, and the MITRA-FR mainly enrolled this population. On the other side, you have more leaflet tethering, more malcoaptation, and a higher EROA for what you would expect given the degree of LV dilatation. So the MR is actually contributing more to the disease, and it does make it's biologically plausible that you would proceed with edge-to-edge repair, and those patients stand to gain the most benefit. And the COAP trial mainly enrolled that population. So looking at I wanted to spend 30 seconds just to look at the three pivotal trial populations side by side, as once you kind of examine those populations, all the conflicting results tend to be a little bit more clear. So if you look at the EROA of the COAP trial, it was 0.4, MITRA-FR 0.3, and the Reshape HF2, which supposedly was supposed to enroll moderate to severe functional MR, had a mean EROA of 0.25 centimeters squared. And looking at the LV dilatation, the COAPT had dilated ventricle, but relatively smaller. So the end-diastolic volume index is around 100, with a capped end systolic dimension of 70, and there was no cap in the MITRA-FR, and more dilated ventricles. And guideline-directed medical therapy, the COAP patient were on maximum tolerated medical therapy and stable for 30 days before randomization, whereas MITRA-FR patients were left for local practice. And the Reshape HF2 had reasonable medical therapy, but they kept enrolling for over 8 years. So there was some variability to the baseline medical therapy, with the SGLT2, for example, being used at less than 10% of the baseline at baseline. So COAPT enrolled mainly disproportionate patients, MITRA-FR proportionate, and the Reshape HF2 had a mixed population. So COAPT enrolled 614 patients with symptomatic moderate +3 to +4 MR to guideline medical therapy plus clip or medical therapy alone. And looking at the two main endpoints for hospitalization, the device group had almost 50% less hospitalization compared to the control group. The hazard ratio is 0.53, and also significant drop in mortality with a hazard ratio of 0.6. Now, it's important also to look at the number of the control group at the end of the enrollment. So at 2 years, and then in the follow-up period, at 2 years, 50% almost of the control group passed away before they became eligible for the crossover at 2 years. And the number needed to treat to prevent one death or one hospitalization within 2 years was around 3. This is an extraordinary effect by the standards of cardiovascular trials. At 5 years, we see the same results. Basically, if you look at mortality in the control group, the mortality was 67%. It was, compared to the device group of 57%, still very high. And death or heart failure still occurred in about 74% of the device group. So even in highly selected patients where you would intervene on the mitral regurgitation, in a population with significant cardiomyopathy, cardiomyopathies are going to do what cardiomyopathies do. And what we're doing here is we're buying time, we're buying quality of life, which is meaningful, but we have to be a little bit more transparent about it with our patients. MITRA-FR, again, randomized patients with functional MR, and as we discussed earlier, it didn't show any significant difference compared between the device group and the medical therapy arm, and we discussed why. And then finally, the Reshape HF2, which enrolled 505 patients with moderate to severe MR who are not candidates for mitral valve surgery. Now, the mean EROA here was actually 0.25, which is considered moderate. And only 14% of patients had an ERO of more than 0.4. The population on average is older, so we get a mean age of 80, low BNP, less renal dysfunction, and the enrollment again went over 8 years. And looking at the primary endpoints, so for a recurrent hospitalization or cardiovascular death occurred much less in the device group, so 37 versus 59% or per 100 patient years. So the rate ratio is 0.64. So there's a relative reduction of 36%, which is meaningful. And the first or recurrent hospitalization alone was also dropped with a rate ratio of 0.59, which is a meaningful improvement. And there was also a meaningful improvement in KCCQ scores, but there is no reduction in overall mortality. And if you look at the subgroup analysis, the effect was similar in all pre-specified subgroups, but there's a few interactions that are good to take home. Patients who were hospitalized within 12 months before randomization had a significantly more benefit. So about 47% relative reduction. So that's very meaningful. And patients who were more symptomatic benefited more. This is the second strongest interaction. And then finally, patients with more MR and lower EF benefited more. So these are all hypothesis strengthening. We already know that patients with low EF, more symptoms, and more severe MR tend to do better. The new signal here is that those who were hospitalized recently within the last 12 months before randomization benefited more from the intervention. And a pooled analysis of all three trials showed the same thing: reduction in hospitalizations in all across the board, with a directionally favorable effect on cardiovascular and all-cause mortality, with the effect size modulated by severity, LV size, and background guideline-directed medical therapy. So if the COAPT criteria tells us which patient would benefit, what does that patient look like? So Adamo and colleagues published in 2021 some registry data, and what they've demonstrated in that registry is that COAPT-like profile or COAPT-like patients did better long-term compared to non-COAPT-like patients. So the COAPT criteria continues to be our best template. And so patients who are symptomatic, EF between 20 and 50%, but not so dilated LV. Their LV would not be so dilated. The end-systolic dimension of 70 or less, PA pressures of 70 or less, absence of end-stage heart failure with no cardiogenic shock, no inotropic independence, and no RV dysfunction. And they had to be on maximally tolerated guideline-directed medical therapy for 30 days, and they had appropriate anatomy. The EuroSMR registry also gives us a good staging scheme and captures the extramitral cardiac involvement in that population. Stage 1, or in that registry, stage 1 is basically patients who had isolated LV pathology. Those were 10%. Stage 2 added LA involvement, 46%. Stage 3, pulmonary vascular or pulmonary hypertension or TR involvement. And finally, stage 4 is when you get biventricular failure. And what the study demonstrated is that you get progressively worse mortality as you progress through the stages. But the nuance effect or the important effect here is that you get improvement in NYHA class across the board. So it's an important thing to tell ourselves and our patients that the prognostic benefit tends to occur at the earlier stages. A palliative benefit does occur across the board. Both are very meaningful, but it's a different conversation. So I want to shift gears a little bit and talk about intervening on moderate mitral regurgitation in advanced heart failure. This is where the evidence is a little bit softer, and the decisions, you could argue that they're a little bit more nuanced and consequential. So moderate MR in advanced heart failure is a different disease. So a moderate MR in patients with a severely reduced EF and severely dilated ventricle is different from moderate MR in your outpatient who is stable with a mildly reduced ejection fraction. So first you have a regurgitant fraction. The regurgitant fraction that occurs with moderate MR amplifies the volume overload in an already diseased and dilated ventricle. Second, even though you get lower EROAs, they still result in elevated LA pressures because that receiving chamber is already lost its compliance. Also, when you look at patients with a severely dilated ventricle and severely reduced EF, these cutoffs of EROA of, for example, 20 millimeters squared for moderate MR were derived from less remodeled population. In a patient with an LV of 220 mLs or 250 mLs, 20 millimeters squared will still result in a significant regurgitant volume that's going to result in elevated filling pressures and neurohormonal activation. I'm not saying that 20 millimeters squared is going to underestimate the degree of MR, but it's these cutoffs were simply not validated in patients with very advanced heart failure, low EF, and severely dilated ventricles. And as I mentioned, the observational data does show that that functional MR of moderate or more does result in poor outcomes over 1 to 2 years. If you look at the image here on the right side, so we're comparing two different hearts. Both have an MR with an ERO of 0.3, a regurgitant volume of 45. But in the less severely impacted heart, where the stroke volume is relatively preserved, the regurgitant fraction is around 39%. When you have compared to the ventricle that's more diseased here on the right side, where the stroke volume is lower of 30 ml, the regurgitant fraction here is 60%. So the message that I want to deliver here is ERO and regurgitant volume alone may not reflect the volume overload that's handled by severely dilated and severely diseased ventricle. Moreover, the Reshape HF2 had a pre-specified secondary analysis done. And again, we just discussed that population. It predominantly looked at patients with moderate to severe functional MR, but in reality, the average EROs in that study was around 0.25, and only 14% of patients met the criteria for severe MR, and 23%, so a quarter of the patient, had an ERO of less than 0.2. And they basically looked at outcomes or the burden of hospitalization in this secondary analysis. So you can see that at 24 months, the time to cardiovascular death or heart failure hospitalization was 35. The incidence of cardiovascular death or hospitalization was lower at 0.65 with a hazard ratio of 0.65. So a relative reduction of 35%, a reduction in recurrent heart failure hospitalization with a relative reduction of 25%, 26% for recurrent hospitalization or all-cause mortality. And finally, most importantly, for the subgroup of patients who had a heart failure hospitalization 12 months before randomization, they derive significantly more benefit with a P interaction of 0.03. Excuse me. All right. So also I want to talk about the expanded registry, which is real-world patients with moderate functional MR or more. And what this registry looked at is basically a combination of the Expand and the Expand G4 registry, and included patients with functional MR. And there were around 350 patients with moderate functional MR, and this is what this specific analysis looked at. And what it's shown is that there is a meaningful reduction in MR, meaningful reduction in heart failure hospitalization, NYHA class, and KCCQ scores. And what I what I really like is the editorial that accompanied that publication by Paul Sriracha, that he describes the findings as provocative and the hypothesis as plausible, but it does require an RCT with mandatory modern guideline-directed medical therapy and core lab MR quantification. My own personal approach for moderate MR and advanced heart failure is that it's usually an intervention of last resort. And so this is my personal approach for managing moderate MR. So it's an intervention of last resort. What I do for these patients is I quantify them rigorously. This is not an intervention that you want to undertake after eyeballing an MR. You want to reassess after genuine guideline-directed medical therapy optimization and repeat your imaging. You want to identify the likely responder. So recent heart failure hospitalization, elevated NT-proBNP, persistent symptoms, pulmonary hypertension, forward failure, and you want to confirm your mechanism, and you want to engage with your heart team early. So you want to explore whether these patients are candidate for advanced therapies such as LVAD or transplant. You don't want to be your intervention to be a distraction for your patient or your medical team than the intervention that actually matters. Again, edge-to-edge repair could be part of the bigger picture, but again, you want to start your evaluation for the patient for goals of therapy and candidacy for advanced therapy early on. I'll show you an example of a patient. This is a 56-year-old female with non-ischemic cardiomyopathy. Her EF is 29%. She has a background history of bicuspid aortic valve disease and aortic regurgitation, underwent a bio-AVR about 10 years prior to this evaluation, and underwent a TAVI in SAVR about a year prior to this assessment. She's on optimal medical therapy and has an ICD for the last 4 years. And she basically has mostly moderate mitral regurgitation. There is some variability. It tends to be more severe, a little bit more severe, maybe moderate to severe when she's a bit overloaded. But for the most part, the MR looks like this. She has an ERO of 0.24, a dilated ventricle, some pulmonary hypertension, and mild to moderate RV dysfunction. Her NT-proBNP is almost 4,200. She had 4 hospitalizations in the past 12 months. So this is what the MR looks like. So we discuss her in detail within our heart team meeting. And given the fact that the patient is on full medical therapy, there's nothing to optimize. She's not a candidate for advanced therapy given her comorbidities. We decide to try an edge-to-edge repair and essentially see what happens. And so we implant a clip in the middle, an XTW, and achieve a great reduction in MR. But most importantly, the last unplanned admission for this patient was actually after the edge-to-edge repair. She did have some other reasons for intervening on the left side. It's because she also had right-sided disease, so she had a lead resulting in impingement on the septal leaflet and significant tricuspid regurgitation. That septal leaflet was plastered against the septum, and you have torrential TR. So one of the things that kind of pushed us to fix the left side is potentially we may in the future intervene on the right side. So about a year after the mitral valve edge-to-edge repair, she had great improvement. She was never hospitalized for heart failure, but because of persistent peripheral edema, we ended up going ahead and implanting what we call a trick valve. So a trick valve is basically a heterotropic tricuspid valve where we implant basically valves in the SVC and the IVC as a palliative measure for the TR. You could argue that we could implant an evoke valve, for example, but at the point of intervention, an evoke was not available in Saudi Arabia yet. It just became available in the last few months, and I think countrywide or nationwide, we had 1 or 2 implants of evoke. Nonetheless, the patient is actually doing quite well after these interventions. One of the few handful of cases where I've actually intervened on pure moderate mitral regurgitation. They have to keep in mind that the guidelines only support intervening on severe functional mitral regurgitation. There was no mortality improvement signal in the literature. And basically, there is a narrower risk-benefit ratio. So you are taking the same risk for the procedure as with severe mitral regurgitation, but the absolute benefit may be smaller. And you really need to be honest with your patient. Most of the time, you really don't understand the impact of the procedure on symptoms or on outcomes. And most importantly, as well, you need to engage with your heart team early on. Again, you don't want your treatment to be a distraction from the intervention that matters. If you think your patient may be a good candidate for things like advanced therapy, edge-to-edge repair may still be part of the bigger picture, but you need to engage with your heart team and your heart failure service early on. Now I want to shift gears one more time and talk about edge-to-edge repair at the extreme, so the end-stage heart failure patients. So stage D patients are not the same as your typical co-opt or mitral FR patient. These are patients that are truly sick, and I wanted to basically show you here the populations of the roadmap study, which is the HeartMate 2 study, compared to co-op mitral FR. And you can see that these patients tend to be younger, they're way sicker and way more symptomatic. 100% of those patients had NYHA 3 to 4 symptoms. 100% were hospitalized in the last 12 months. And the other parameters look somewhat okay, but edge-to-edge repair patients tended to be a little bit older. And if you look at the mortality and the outcomes of these patients, so focusing on the first two lines here with the 2-year follow-up, so these are patients with advanced heart failure. So roadmap patients, again, the HeartMate 2 study, had a mortality of about 30 to 37% in that population. And the non-co-op like registry data patient had a mortality of about 45% at 2 years. I know it's not a perfect comparison. There are two different studies with two different populations, but just to have an idea. And then looking at the 5 years of follow-up, if you look at the outcomes for the co-op, the 5-year data, the patients had the device group had a mortality of 57%. And if you compare that to the Momentum 3 5-year follow-up study, so this is for the HeartMate 3 study, the mortality was 42%. So they had a little bit better survival. And most importantly, patients who underwent transplant had even better survival. So the treatment at the end stage, when the ventricle is the problem, is actually going to be your LVAD and your transplant, not, again, edge-to-edge repair. Edge-to-edge repair tends to be a complementary thing. It may be part of the puzzle, but it's not the main goal, unless the patient is not a candidate for either therapies. So when TEER is the wrong answer, and when to think about LVAD or transplant, when you have severe LV dysfunction, severe heart failure, recurrent hospitalizations, the patient is intolerant to medical therapy, they're on high doses of diuretics, and they have adverse hemodynamics in your right heart cath. So if you have a couple of those things, you may want to evaluate the patients along with your heart failure service to determine if they are candidates for other therapies. So I don't want to frame here that edge-to-edge repair compares to LVAD. These are two different modalities, but you want to choose your patient based on the phenotype. So the ideal patient for edge-to-edge repair is the patient with severe disproportionate MR, LVEF between 20 and 50%, not so dilated ventricle, not severe pulmonary hypertension. The procedural profile here is a little bit more benign. It's a short procedure. It's suitable for frail patients. And again, the best evidence here is for the co-opt-like patients. Whereas in the LVAD, it's for patients with severe LV dysfunction, patients with Intermax 4, so these are your NYHA 4 symptomatic patients, to the patients with sliding inotropes or unresponsive to medical therapy who may be eligible for transplant or destination VAD. The procedure profile, again, it's a sternotomy, and it's a more invasive procedure, but the survival is definitely better in patients who are sicker, unless they have some contraindication for the procedure. Again, there's higher procedural risk. There's risk of infection, bleeding, stroke, etc. But for the right patient, it is the best approach. So if TEER was a pill, what are the benefits of edge-to-edge repair in this population? First of all, compliance. So 100% compliance. It does improve hemodynamics, so it does raise your blood pressure. And studies have shown that. So it gives you room to titrate your medical therapy. So it does unlock guideline-directed medical therapy titration, and this is well documented. It does raise cardiac output, reduces mortality in the right phenotype, reduces hospitalization, and does preserve your option. So it does not preclude from LVAD or transplant. It can continue to stay as part of the bigger picture. And it does have an excellent safety profile. So the Mitra Bridge study basically effectively looked at this population. So 153 patients with advanced heart failure, potential transplant candidates. They had a median age of about 59 and an EF of 27%. The procedural success was very high. 21% of the patients reached transplant, and 22.5 of patients, which is very impressive, came off the transplant list because they no longer needed it. They improved, or they stabilized. And 64% were free of MACE at 1 year. So again, it's a good option as part of the bigger picture of this either VAD therapy or transplant, and that's why it's very important for this population is to again engage with your heart failure service early on. What about VAD plus clip versus VAD alone? So this particular study looked at this. It's a very small study of 27 patients in each group, and they were propensity score matched. And the question is here is that if the patient had significant functional MR, does clipping the valve before VAD implantation improve the post LVAD course? Because theoretically, you can have with functional MR, you can have pulmonary hypertension and raised PA pressures. So does MitraClip result in any improvement? And what the study showed is that the procedure was safe. There was no difference in mortality, and it does lower PA pressures and it lowers wedge pressures. There was also some concern about the iatrogenic ASD from the MitraClip, because if you decompress the ventricle and the left atrium, you can theoretically you can result in a right to left shunt. But the iatrogenic ASDs were found to be non-significant. So it's something that you can consider for patients with significant functional MR, especially if they have elevated PA pressures and wedge pressures. So even the co-opt 5-year follow-up study included some patients who underwent LVAD or heart transplant at last follow-up. So this just demonstrates that, again, this procedure does not preclude from advanced therapies. This is a case of a patient. I think he was around 64-year-old patient with a severe, late presenting inferior MI and severe MR in the context of pap muscle rupture. This patient was referred to us from one of the peripheral hospitals, and you can clearly see on the TEE, on the 3D, that you can see the head of the pap muscle. And you can see here that you basically have a flail anterior leaflet. And essentially, the entire medial side of the valve was actually wide open with severe mitral regurgitation. So in this patient, we did proceed with a salvage therapy after he was too sick for the surgeons to take him to the OR. He was in really bad cardiogenic shock, obviously, and we ended up implanting 2 mitral clips. And you can actually see that the head of the pap muscle is almost like wedged between the 2 clips, and you can also see that on 3D. We had great anatomical improvement. The MR on follow-up was moderate, but the patient, because they came to us way too late, the patient eventually did start to have eventually multi-organ failure, and eventually did not do well despite the great anatomic result of the MitraClip. So we do these cases sometimes. So TEER in cardiogenic shock. So does that help with the outcomes? So I wanted to put the 3 biggest study in this area side by side. The first one on the left is the largest registry. The middle one is the pooled analysis of all the observational studies. And then the last one on the right is the interesting single center experience. So the first one on the left is the STS TVT registry. This was a study by Trevor Simard and his colleagues. Trevor is actually a graduate of the Ottawa Heart Institute. He was my co-fellow when I was training there. So he's currently, I think, a cardiologist at Mayo Clinic. And his study included about 4,000 patients and patients with cardiogenic shock. both cardiogenic shock due to LV failure or acute MI, and the device success rate was 86%. The 1-year mortality was lower in the patients who had a successful procedure, so 35% versus those who did not or who had a failed procedure of 55.5%. So it kind of showed a signal for potential mortality benefit. And the adjusted hazard ratio for death is 0.5, around 0.5. So, and if you look at the middle study that included all the observational studies together, included about 5,500 patients. And again, the implantation rate was around 86%, so the same one there. And the 30-day mortality was around 14%. The post-MI subgroup 30-day mortality was around 20%, and rehospitalization was 9%. And if you look at the single center experience, they had a different approach. So anyone with cardiogenic shock would basically get a mandatory mechanical support with a balloon pump or Impella within less than 6 hours for medical contact, and then edge-to-edge repair. And the median admission to TEER was around 2 days. The success rate was 83%. The in-hospital survival was 86.6%. The 90-day survival was 80%. Now, in a population where the mortality has been documented, if left untreated, of north of 50%, the overall finding that of a device success rate of 86% and 75 to 85% in-hospital survival across all three studies, I think is very promising. We do have an RCT that's currently recruiting, and I believe St. Michael's Hospital is part of this study. It's called Capital Minos. It's out of Ottawa Heart Institute, and I think the Mayo Clinic group is part of the recruiting team. And I remember seeing both Sunnybrook and St. Michael's Hospital as recruiting centers. So the phenotype decides who benefit and who doesn't. So your best bet for edge-to-edge repair, again, is disproportionate MR with preserved RV function, no inotropes on medical therapy. And it tends to disappoint in patients who are crashing or who are requiring inotropes, severe RV dysfunction, pulmonary hypertension, or proportionate MR. These patients tend to benefit more from LV unloading therapies. So, but in true life and true practice, the true answer for most patients lies in between, and these answers are individualized as per patient basis. Again, procedural pearls in patients with advanced heart failure. So you need to optimize your volume and then pre-position your heart team as to what is your bailout strategy. Is this patient a candidate for surgery? Are they a candidate for advanced therapies or mechanical support? What is the goals of care of the patient? And what are we trying to achieve? Intraprocedurally, you need to coordinate with your anesthesiologist. Of course, they have to be a cardiac anesthetist who is well versed in dealing with patients like this. Mechanical support should be on standby. In our local practice, actually, in most patients with very advanced heart failure, hypotension at baseline, previous admissions with requiring inotropes, we tend to do these procedures with a balloon pump. The theoretical reason, and this is mainly pushed by our anesthesiology team, is that there is always this risk of afterload mismatch when you reduce the MR. So they're more comfortable doing the procedure with a balloon pump and then taking out the balloon pump once everything is done. You need to mind your gradient. Again, you need to reduce your MR significantly, but you need to make sure that you don't result in significant mitral stenosis, and this is automatic as part of the clip procedure, but maybe more hemodynamically significant in patients with a very advanced heart failure. Perfect is the enemy of good. You know, I try to achieve a reasonable result with the minimum, with the least complications. Sometimes if you try to trace every jet of color in the cath lab with a clip, you will result in a higher gradient, or you have a higher likelihood of resulting in a complication. And then post-procedure, you need to retitrate guideline-directed medical therapy, intensify your diuretics. Edge-to-edge repair is an adjunct to your treatment. It's not a replacement. So where do the guidelines stand? So right now we have a class 1 recommendation for treating functional mitral regurgitation if they meet the co-op criteria. And that's the only current indication. There's a 2B indication in the European guidelines, I believe, if you have functional mitral regurgitation. The class 1 is only for ventricular MR. For the group that we just discussed, the evidence is less clear. There's definitely no signal of mortality benefit, and you need to basically discuss these patients individually along with your heart team. So going back to that first case, so the 64-year-old man with non-ischemic cardiomyopathy, EF of 28%, ERO of 0.4 with severe MR, severely dilated ventricle, and moderate pulmonary hypertension. So they do meet the co-op criteria. They do have disproportionate MR. The ERO is out of proportion for their LV dilatation. So edge-to-edge repair is reasonable, for because they meet the co-op profile, so they will benefit. But also they should be considered for more advanced therapies if they were deemed to be candidate. So what we still don't know, we don't really have good RCT data for patients who are in cardiogenic shock or patients, for example, with severe RV dysfunction. The long-term durability of our therapies in functional MR beyond 5 years is still a question mark, and we don't have great data there. And a lot of these studies and the trials that we look at right now were done when the guideline-directed medical therapy was quite different. So before the age of ARNI or SGLT2. And perhaps it would be nice to know the impact or the interaction between the current and latest guideline-directed medical therapy with edge-to-edge repair. We don't know the cost effectiveness in patients who don't meet the co-op-like criteria. So is it cost effective to manage patients purely for reduction in hospitalization and improved quality of life? And then finally, I wonder what the other technologies like TMVR and annuloplasty and how they're going to reshape the landscape within the next 5 years. So I have 3 take-home messages. TEER works, but it works best when the valve is the problem and not the ventricle. Its most meaningful role in advanced heart failure is integrative, so it's part of the bigger picture, as I discussed. And the interventional echocardiographer is central to the procedure and to the heart team with patient selection, procedural guidance, and basically having an expert team available to you in the procedure does make the difference between a successful and unsuccessful intervention.